Thanks so much, Aaron. And move immediately to our next presentation from Courtney Habina and Julia Hughes-Girard from the mental health team from University of Calgary and Alberta Health Services. I'll turn it right over to you.
Perfect. So I'm Julia Hughes-Girard. I'm an assistant professor in the School of Nursing in the faculty of nursing at U of C. Sorry, I'm a little bit jet lagged too. I was at another conference in France, so I'm happy I can spell my name this morning. Our other team member who couldn't be with us today is Dr. Dimitropoulos. And just a brief overview of what we'll touch on in this presentation. So using any mental health platform for collecting PROMs, implementation of a survey, and then some qualitative interviews that were done to give a little bit more context to the findings. So e-mental health, whoa, I'm really loud. E-mental health is an innovative approach that provides convenient and confidential mental health supports. And in our case, in our project, we were using it for emerging adults population, so that kind of 15 to 25-year-old range. It's really convenient for people who like using it, particularly emerging adults who are always on their phones. And really, the project as a whole is looking at the implementation of a particular e-mental health platform, named there, looking at it within specialty mental health settings through AHS, some primary care networks and schools all over Alberta. And really what these emerging adults are doing are completing PROMs and then looking at the recommendations that come up associated with those PROMs that are built into the platform that we've decided to use. So as you can see there, it's a collaboration between some folks in Australia and folks here in Alberta. There's 38 sites participating, and it says it empowers EAs to participate. That's what we were hoping it would do. So, and what is nice and kind of speaks to the whole, what's useful about e-mental health, for especially in that emerging adult group who's so used to social media and immediate gratification, they get some results back right away. So there are the aims. That's the number of people. So we had actually some really good response. 195 people actually filled out kind of our surveys, seeing how we were doing. We use a CFR, which I think everybody has heard about already. And, oh, no, it was, the paper has actually been accepted. So I am not going to read all these numbers. They're there. Really just want to highlight, though, that the majority were females, which is to be expected in this kind of research. And the majority were of European descent. Most of the youth that emerging adults that participated were employed. And then you can see that we did have a good kind of breadth of professions represented in our provider responses. So just to orientate yourself, because I had to do this morning too, so the top is just breaks down who replied that actually used the platform, and we also solicited feedback from people who decided not to use the platform at all. So the people who didn't use it, we knew that they didn't use it because they were invited to use it. They consented to being followed up, but then we never got anything in terms of survey data back from them. And so if you can see at the bottom, I think, again, there's a lot of numbers. The really big thing, I don't know if there's a pointer, and I don't know if I'm going to actually attempt to use the pointer. But the one thing to look at is, so under the non-users, as individuals, those are the clinicians. So a lot of clinicians said the youth weren't interested, so that's why they didn't use it. But if you look to the other side of the table, at the bottom, there's the pointer, but I don't know how to use it. At the bottom that says things that would help with intake from the youth, it says if the providers were interested in using the platform. So I think the biggest takeaway from here is that everybody is interested in using the platform, but they think the other people aren't interested in using the platform, so that's why they're not using the platform. It sounds like a conversation with my 14-year-old. So, really just as we're looking forward to continuing implementation, this really highlights somewhere that perhaps we need to work on a little bit, is why aren't they talking to each other? So a little bit more of this data, and you can see that perhaps these are some reasons why people aren't talking to each other. So you can see that the providers were using the data that the youth put in, or emerging adults, I'm going to call them youth, but emerging adults put in less than half of their sessions. So if you aren't getting any follow-up from the data that you're providing, you probably are thinking that people aren't interested in using it with you, and then you're less likely to use it. And then you can see that the youth there are putting it in it is almost evenly split between 2 to 10 times a month and once a month. So can we kind of look at perceived support? And so for the youth and young adults, this was perceived support from the provider to actually use the platform, however they define that as. And so, again, interesting is that at the top, the providers were using it in less than half the sessions, but the youth feel like reviewing the results is really helpful with their provider. So something else to keep in mind and perhaps going forward with implementation. So again, we asked a lot of questions, but again, I think it's really just highlighting in all of this is that the platform, everybody feels that the platform is useful, e-mental health is useful, PROMs are useful, but there's a bit of a breakdown in conveying that utility or that perceived utility between each group of providers, and that really does affect implementation success and ultimately care. Right, and outcomes based on this. Ooh. So again, outcome monitoring was a big one. A collaborative working relationship with youth was a really interesting one. We were glad to see that 54% of providers thought it built on collaborative care, because again, involving youth in their care and that shared decision making, we know leads to improved outcomes. And happily, youth had the same kind of numbers. They also felt that it was a good collaborative relationship, so that was really good. And people found it easy to use, which is another important thing when you're looking at implementing PROMs and e-mental health. So main takeaways, again, it was positive. It promoted engagement and collaboration and really supported mental health outcomes, both the e-mental health platform, but also the addition of PROMs in there as well. We need a little bit more education and training and talking to each other. But if anybody knows how to make that happen with emerging adults and adults, please let me know. I'm headed in that direction too at home, so it would be really useful for me as well personally, also clinically. And you need to really highlighted that need to include both perspectives, right? So the people using the platform and the people administering the platform are using it for clinical care, and then from a patient and client point of view, because otherwise we would have never seen that mismatch of thinking, everybody's talking to each other and it's great, and we all are troubleshooting the same things, and we're probably not, actually. And so, Courtney is going to talk about the findings of the qualitative surveys that we did, just to add a little bit more context around perhaps what's going on, what are we missing, and why did we see these numbers. Thank you.
Okay, so we did qualitative interviews with 11 members of leadership from these different sites, from the EMH project wide. And the aim of those interviews was really just to explore their perspectives on implementing PROMs through the EMH platform. And directed content analysis was conducted by a member of the research team and checked by the principal investigator. As for our EAs, we did a sub-study within the EMH project to look at how the PROMs can be used to stage clients into different treatment streams within the clinics. So within 2 specialty mental health clinics in Calgary, we interviewed 22 different emerging adults, and the aim was to explore their experiences with this stratified care system and PROMs. So a little bit about the stratification. Receiving accurate diagnostic assessments and choosing appropriate treatments can be a long and difficult process for emerging adults. A lot of them don't know what's offered in different clinics, they don't know where to start, and there is still a bit of a stigma attached to reaching out. So adapting a transdiagnostic approach using PROMs could improve assessment and treatment for emerging adults. And the stratified care model is a multi-directional model that triages individuals into higher or lower intensity services based on their current level of impairment. And the two clinics did use this. So each clinic might have different levels, but they were still using the PROMs to make those decisions and monitor treatment progress throughout clients' treatment. So diving into the good stuff now. So for our intervention characteristics domain, these were questions regarding the EMH platform itself. And leaders mentioned that the web-based nature may be a barrier for EAs, as the demographic nearly all has access to smartphones and prefer mobile apps. Really logging into the platform, remembering your login was seen as a barrier for the emerging adults. While NOL offers a wide array of digital resources, the sheer volume often led to confusion and difficulty navigating the platform, even with onboarding guidance. And the length of the questionnaires required for measurement-based care also became overwhelming for some individuals. There was 23 different domains on our platform, and it took about 45 minutes to sit down and complete everything all at once. So that was seen as a bit of a barrier. Moving forward in different sites, we are looking at tailoring those domains down to help with that. As for our EAs, the majority of participants wished NOL was available as an app. Many reported those difficulties navigating the platform, so there was that alignment between the leadership perspective in the clinic as well as the EAs. And the EAs reported one of the main reasons for not completing PROMs was they just kind of forgot to. So they went on to explain further that if it was an app and they could enable some push notifications to remind them to take those surveys, they would have used it more. So here are some quotes to highlight that from leaders. So the platform lowers the caseload for clinicians and social workers for those onboarded, and they mentioned the potential of the platform to continue to lower the caseload if more youth are onboarded because they are connected to those types of resources. And as for the REA, do you feel the platform has allowed you to take more of an active role in your treatment at all? Yeah, actually specifically, that's kind of what I like about it most. Like the two of us working together instead of a one-sided conversation at me about my problems. I can have informed input on my own problems. Now moving on to the inner setting, these were questions that focused on the setting in which the platform was implemented. There was some concerns from leadership about maintaining knowledge of the platform among providers. This is really in line with the presentations earlier that there's a need for ongoing education. If you don't use the platform, you kind of lose it. You need to be using it regularly to stay up to date with it and know what are the changes that are coming with all of the updates to be able to pass that on to your EA clients, or else there's just a little bit of a confusion. But on the other side of that, leadership also mentioned that NOL's self-management nature aligns with the preference for giving clients more autonomy in their treatment, empowering them to guide their own care. This patient-centered approach is preferred by providers who feel the health system often dictates care rather than listening to what clients actually want to work on. And then from our EAs, there was a call for better training processes from all parties. They said the initial training was really good, but again, if you're not using the system regularly, you do kind of forget where things are and how to do just one survey or one domain instead of all 23 at once. Participants also enjoyed debriefing those NOL results with their provider, valuing that resulting clinical insight provided by their therapist. So a couple quotes here. It's not the education that the lead gave. It's more the continued education of the practitioners using NOL. If you don't use it, you lose it. And then from our EA, I think that it would have been nice to have another person who knew the platform with me while I did it my first time around. Say my therapist was there and she knew how to use NOL already. So she was like, okay, I'll walk you through it and we'll go through it together and teach you how to use it. We did follow up in this interview to ask, would it have been helpful if a member of the research team sat down and went through it with you? And they said, really, I want to know how this is going to impact my care. I want to know what questions are most important from my clinician. So I do those ones first, and if I get burned out, then it's not a big deal. I'm not missing the ones that they were really interested in. As for our individual domain, these are questions focused on the roles and characteristics of platform users. There was some concerns from leadership about balancing implementing the platform with other responsibilities. We know clinicians and providers are super busy. There is tons of demands on them in their day-to-day roles, so they did say that they didn't have probably enough time to sit down and give the platform as much attention as it needed. But on the other side of that, leaders did appreciate how the platform enables EAs to access tools when needed, fostering that independence. They viewed the platform as enhancing the depth and quality of conversations between EAs and providers, providing a more meaningful and resourceful experience that aligns with their focus on client growth and support. As for our EAs, many of them found the PROMs long and very time-consuming to complete following therapy or in session, especially right after sessions. They did mention that, there's that emotional fatigue and kind of burnout, so they liked being able to go back and complete it when they were feeling up to it at their own pace. There was issues with various PROMs topics, and some of them were triggering and overwhelming for some individuals. Specifically, this can be some of the domains regarding eating behaviors, physical health, spiritual health, those kind of things. And EAs did like the fact that they were allowed to skip any questions that they didn't want to answer. They did say that was one of the key benefits of using the platform. As for another facilitator, using InnoWell regularly within and outside of sessions led clients to feel more accountable to follow through on their treatment plans specifically. So from our leadership, to be honest, using InnoWell is not going to be a top priority because there's so many other things that we need to set up at the beginning of the school year. This also just highlights that it's really important to know your population and your settings, because when you introduce it can be really important. It wasn't that they weren't interested just at the beginning of the school year. There's so many other demands. And then from our EA, with my therapist and stuff, I filled out the summary survey. And then every therapy session, it would be a goal for myself to fill it out, so she would know where I was at. But I don't think if I didn't have those therapy sessions and I didn't have someone else holding me responsible to fill out those surveys, I probably wouldn't have done it as much. So, we saw this in our sample, we saw this in the survey data. When providers and clinicians are bringing up, oh, I saw this in your results, or let's debrief this and talk about what this question's actually asking, clients really enjoyed that. But when they would just do it and it was never talked about, they were kind of like, what's the point? For our implementation process, these are questions focused on the activities and strategies used to implement the platform. Despite efforts to adapt, some clinicians quickly backed out of using InnoWell when the assessment process proved to be too time-consuming or complex. This led to a ripple effect with other providers following suit. The lack of accountability measures further contributed to this resistance, as clinicians felt free to abandon the platform without facing any consequences. And then on the other side of that, the facilitator was improving coordination of non-crisis situations. So beyond crisis response, leaders acknowledged that better teamwork could also improve day-to-day coordination. For example, better communication between providers and clients was needed to ensure clients were aware of those email invitations to use the platform and to check the platform to see if their clinician asked for them to complete any specific domains before their next session. As for our EAs, there was that low engagement due to provider integration. So when InnoWell is included in those therapy sessions and their provider does show enthusiasm, clients are encouraged to continue to use the platform and they find it more beneficial. Out of the 22 clients we interviewed, 10 participants disclosed that their provider did not integrate InnoWell into their sessions, and when asked if they wished if it was, every single one of them said yes. They said they don't want to talk about it for the whole session, but they want their results explained to them because they don't even know if they're doing it properly in the first place. When providers would encourage InterWell integration in session, EAs reported it allowed them to take more of an active role throughout their treatment, increasing their engagement and accountability during treatment, and increases follow through with their treatment plans. This, in some cases, led to being connected to other services, and participants also mentioned it encouraged their engagement in other services offered inside and outside the clinic. So these are pretty long quotes. How am I doing for time? Okay. So from our leadership, one of the clinicians was like, no, this isn't gonna work for my practice. And he backed out very quickly before trying a lot of the changes or trying to figure out different ways of getting the kids onboarded. And then because he backed out, I feel like other providers felt like it was okay to back out too. So that kind of highlights that point. And then from our EAs, my provider obviously asked, do you take your surveys? And I'm like, yeah, but then nothing goes from there. So I kind of wish there was a bit more of in-person interaction where you could actually reflect upon it. If you aren't talking about it with someone, you're never actually going to develop a solution to it, which is something I think could be initiated more by a clinician. Okay, Julie.
That's me again. Uh-oh. Thanks. Me again. So really, some of the main takeaways from our whole project to this point anyways, is it's a really convenient, confidential way for the most part to provide mental health support and to collect PROMs from this age group. Both providers and EAs look at this as a positive addition to their healthcare and mental health care, but there really is that need for more education and more training and a little bit more ongoing support past the initial kind of introduction and integration into care. And really, the interviews highlighted just kind of really general acceptability and, again, that kind of long-term commitment from leadership. And so we did do some decision-maker interviews at higher levels than the clinicians and immediate supervisors, and some of the preliminary results, which aren't on here, are really highlighting that need for the long-term commitment from higher up in the system and not just the front line and immediately impacted individuals. I want to thank the team. They're all there, and the funders. We're a nice big team. And Liana's there too, so she's over there. All right. Okay, so after 4 years in the field, the e-mental health team understands the critical role of measurement-based care, thank you, in improving client outcomes in mental health and enabling a learning health system. And so the team is building an alliance of innovators and like-minded people with an interest in leveling up digital measurement-based care in Alberta. And so if this sounds interesting to you, if you want to come and join us, we're a really fun group of people. We'd like you to share your ideas and shape what you think this might look like in Alberta. And so if you want, I'll leave this up for like a couple minutes. Please scan the QR code, fill in the survey, and Leanne especially, and her team will get in touch with you, and you can come join us. Have fun. Thanks so much.
I'll ask Erin to come up and join this really fun group of people. So thank you, Julie and Courtney, for sharing a little bit about the e-mental health project and the team and the invitation to collaborate. And as I said in the outset, sharing and learning is and expanding your networks is a big objective of the meeting that we have and the Aperçu team. So with all the presenters here, I'll open it up, see if there's any questions for our presenters on the projects. And while you're thinking of it, maybe I'll start. I wondered, Erin, you alluded to in your presentation a decision was made to drop some measures, the suicidal risk measure. Can you give some background as to that decision? What happened?
Sure. Is this on? Yeah. Actually, 2 were dropped. So the RCADs we dropped early on from the walk-in because they felt like it just didn't fit. They're not diagnosing children. They're like addressing functional concerns in the moment. So the PTQL was viewed as the best fit for that. And then the Columbia, so it is an ITROM recommended measure, but it's never actually been validated as a self-report in children and adolescents, which turned out to be a big problem. So asking about suicide in the clinics, the day hospital and the ICTS, that was kind of no problem. They're coming from other treatment facilities. They've been asked about suicide thoughts and behaviors before, but then in the walk-in clinic, that was not the case for the most part because they're not already connected with treatment teams. So there's kind of two issues, just that one idea of it being triggering, and then the other idea of it's a screener tool, so it should be over-capturing risk, but it was actually the opposite. So children were under-reporting. So clinicians are, of course, asking anyway. And so once we realized there's that misalignment, it was just very clear that there's like no value to keeping it in there. That's the whole story. Well, most of the story.
Got a question while Mike's going over there. For Julie and Courtney, the measures that are in you talked about long measures. Are there standardized measures like these measures for mental health?
I'm trying to remember what all yeah, they are. They're all validated standardized measures that are used in INOWELL in this particular platform. And they're long. My understanding from it was trying to capture the gamut, but now what sites are moving to a more individualized and more representative kind of suite of standard measures to try to shorten it, but also to actually capture what's useful data for their clients.
Great. Thanks. Linda.
Hi, everybody. Linda Watson from Cancer Care Alberta and leader of an integrated program in the cancer program here in Alberta. Couple comments I hear over and over about the importance of clinicians using the data. So I would just echo that and exclamation marks behind it, because there is very little value to pro collection if it's not driving a conversation, changing how care is delivered, helping somebody understand what's going on for the patient and helping them get the help they need. So I think that's just such a huge piece of implementation that we just have to get ourselves around. But I would say that there is lots of evidence that empowering people with their own data is actually therapeutic if you can make it usable and easy to interpret to the individual. So I guess, Erin, I was thinking about your talk and just wondering, you made a really brief comment about the results would be shared with the patient at the decision of the clinician. Did your study and program really look at how giving those results back to the patient changed their behavior or allowed them to advocate for themselves or had a different conversation with their caregivers about how that difference? You talked a lot about the difference between the caregiver and the individual. So was there any look at that and giving the results back to the patient and seeing if that actually fostered communication between them?
We didn't look at that specifically. I would say we really wanted a platform where patients would be able to just immediately have access to their own data, see the results. But yeah, just so many barriers with getting that up and running. So yeah, I can't say we looked very specifically. And if you saw, you noticed there's a few, the one clinic, they're using the data. The other two clinics, they're not using it. So to even say, we did ask a question in the clinician survey about, are you sharing it with youth? And that was, I can't off the top of my head remember the exact percent, but it was definitely lower than how often it's informing treatment. So yeah, it was recognized as a priority, but then it was one thing that had to go when we it was go time, make this happen. So. But yeah, it would be very interesting. And then just the way of presenting that data in a way that makes sense to children and youth, I think, is an additional kind of big research question right now.
Yeah, awesome. And I would just say to your comment about advice you were given about integrating into Connect Care, And I had the same question about the second presentation about external platforms and like how is it always need to be as complicated as sending somewhere else? So I would just say from an integration perspective, we have kind of cracked the nut on doing our pros in CCA through the portal. So in Cancer Care Alberta, we have about 60% of our patients are now using the MyHS Connect portal, and we built those questionnaires for pros right in the portal, and people are completing them as part of their routine care. So really, really exciting to see. We've been live with Connect Care for about almost 2 years. It'll be 2 years in November, and about 50% of our e-pros are coming through the portal now and going right into the chart. So it decreases, like, I think there's anything we can do that makes the data easy to use in the clinical encounters, timely, easy to interpret at my fingertips when I see a patient. And those are things that we really need to be persistent on and figure out how to integrate in that way. So thank you for your great work.
Yeah, that's great. Just like one question back to you. You must have a specific strategy for getting people onto the MyHS Connect then? Is that like at an intake time point, or how do you?
That's a great question. We have had particular focus on helping, like just making the portal people more aware, and we have kind of integrated it into our patient education resources, integrated it into our web presence for our patients, and at intake, encouraging, like having our staff encourage that they sign up. But I think in the literature, cancer patients are the most likely population to really take up portal use. So we're really excited about the percentage of uptake that we've had, because I think it's way outstrips the rest of other programs in AHS, because we've actually went live with a workflow that integrated ePros right at go live, which I think was also a very important strategy.
Yes, because building stuff after the fact is also the second thing that got in the way. But
And then just kind of on that note, the NOL implementation team is meeting with AHS to build it into Connect Care as well.
I will just add, because with this project, we also included schools and primary care networks who aren't necessarily part of Connect Care. So that's the next, maybe in the future, totally, right? So that's the next kind of thing on the list, is how do you find an outside provider that can integrate for people who don't have the option of being on Connect Care.
I'm happy to say that I believe now any person who has an alberta.ca account and My Personal Health Records now has access to My AHS Connect, even if they don't have an AHS provider. So that's a relatively recent piece. I know that's different in pediatrics and young adolescents, but important to understand.
Thanks, Linda, for sharing that, the experience in Cancer Care Alberta as well. Any other questions or comments for our panelists, presenters? If not, you join me in thanking for sharing that experience and those presentations.